Okay, in this short video, we're going to talk about stability and range of motion and some ligaments and burses. So the joint that I chose to show here is the shoulder joint. When we talk about the shoulder joint, we're really talking about the glenohumeral joint. Okay, so this is the head of the humerus, here's the scapula, up here is the clavicle, and here's the acromion process. And the acromion process and the clavicle meet, forming the AC joint. So what are the other structures? Well, right here at the top of the scapula going to the greater tubercle is the supraspinatus. Here's the supraspinatus tendon attaching to the greater tubercle. Now, this is the subacromial bursa. Here's the acromion process, so underneath it, subacromial bursa. There's also a subdeltoid bursa, which would be where the deltoid muscle is, right around here, subdeltoid. Now, the problem here is as the arm abducts, it can compress and squeeze this, okay, and pinch it. If this thickens up, as it is here, if the supraspinatus thickens, then the space underneath the acromion process really diminishes and the bursa gets compressed and becomes inflamed, called a bursitis. So here we can see the clavicle. Here's the acromion process. We do have some ligaments, right? Ligaments go bone to bone. So we do have a ligament going from the clavicle to the acromion process. We have ligaments going from the clavicle to the coracoid process. This is the conoid ligament and the trapezoid ligament. And then we have one going from the acromion process to the coracoid process. This ligament is a troublemaker. This coracoacromial ligament is a troublemaker because think of it, ligaments go from bone to bone to prevent displacement. So we can understand going from the scapula, from the coracoid to the clavicle, we understand that we need ligaments here to prevent separation of the clavicle from the scapula, or the clavicle from the scapula, right? We have ligaments there. But the coracoid process and the acromion process are both on the scapula. They can't move, they can't dislocate. So I call this the troublemaker because this becomes the roof, right? This is what we call the coracoacromial arch, or the roof, which becomes a compressor when the arm abducts. So when you bring the arm out to the outside during abduction, now you start to get the supraspinatus muscle, which is here, right? If we go back, here's the supraspinatus muscle. And now as this arm goes out to the outside, the head of the humerus, the supraspinatus tendon is going to come up and compress the bursa up against the acromion process, so you can get a bursitis. So this arm abduction, constantly, you got the supraspinatus, then you got this subacromial bursa, and bursas are designed to separate two adjacent structures, like a buffer, like a washer. If you put a nut and a screw together, sometimes you have a washer to act as like a little bit of a buffer to prevent irritation. Now you got this bursa that's being compressed by this ligament, the bone, and possibly the supraspinatus that's inflamed. Sometimes the bursa itself could be irritated by degeneration between the AC joint, which is very common. Between the acromion and the clavicle, you can get little osteophytes or bone spurs that can compress the bursa. And each time the person abducts the arm, they get this pinch. So they call it an impingement syndrome. When the arm's hanging down to the side, not too bad, but as soon as they abduct, sometimes that initial abduction, right, is not so much a problem, like 0 to 60 degrees or 30, 40 degrees, not so much. Then they go like 60 to 100, then it becomes this painful arc, and then they're free again. So it's like no pain on initial abduction, then you get this painful arc, and then it dissipates again. So they call that shoulder impingement syndrome. And there's a combination of things that really go together where I've often seen in my practice this like triad of things where they'll get a subacromial bursitis, they'll get bicipital tendonitis, and then there's usually labral issues like a labral tear between the glenoid cavity and the head of the humerus. Okay, so shoulder issues usually are not independent as one slight injury, usually dominoes to other things within time. And that's because the shoulder joint, the way it's designed, you know, it's this ball and socket, but the socket isn't very deep like the hip joint. It's shallow. So you have this large head of the humerus with a shallow glenoid fossa or glenoid labrum, which offers you incredible range of motion, but also makes you very prone to injury. So there's lots of soft tissue structures around it to support it, like the rotator cuff muscles, right? And then the ligament, the joint capsule around the shoulder joint as well. And it is a synovial joint. You have synovial fluid in there. So one of the ways bursitis is evaluated, or impingement, is this Hawkins-Kennedy test, where you can see how the clinician has the patient's arm bent in this direction, they stabilize the elbow here, and then they internally rotate the shoulder by grabbing the forearm and pulling it down. When they pull it down like this, it really closes that joint and impinges it. And if that sends them through the roof, most likely it is impingement syndrome or that subacromial bursitis. And you really have to cool that and rest it off for sure.